Hello, I'm Dr. Nicholas Tedesco D.O. I'm the Associate Program Director of the Good Samaritan Regional Medical Center Residency Program in Corvallis, Oregon. Today we'll be lecturing about revision total knee arthroplasty as part of our ongoing didactic sessions that will supplement the formal in-classroom case-based learning. I do own stock in ROM Tech, which is an orthopedic rehabilitation company, but they have nothing to do with this lecture. Today we're going to talk about the etiologies of pain and dysfunction after total knee arthroplasty, the evaluation and approach to the painful total knee arthroplasty, and then once you've figured out that a revision needs to take place, the goal of the revision, the techniques, how exactly you're going to accomplish this, how you're going to deal with structural deficits within the bones. Greater than 50% of all revision total knee arthroplasties occur within 5 years of the index procedure. So many of these may be owing to surgical technique or preventable issues, as well as patient-based issues that may have been prevented, such as risk mitigation prior to surgery and other things. However, sometimes there are structural failures or problems that can be completely unrelated to technique or patient-related factors. So classic intrinsic or intra-articular etiologies of a painful knee replacement. Number one, you've always got to rule out infection or a septic failure. 1% of these cases are revised due to infection. Instability is another issue, whether it's axial, flexion instability, coronal plane instability, those sorts of things. Malalignment, again, which could lead to instability, but sometimes the biggest issue is maltracking of the patellofemoral component, and patellofemoral maltracking is the leading cause of revision surgery, especially early on. Aseptic loosening can be an issue where either the implant debonds from the cement or the cement from the bone. You can have excessive or eccentric polyethylene wear. You can develop osteolysis as a result of the histiocytic response, not osteoclastic. It's more common in uncemented techniques, and you can see backside wear between modular polyethylene inserts and the tibial tray that increases polyethylene wear, leading to this osteolysis. You can have frank failure or fracture of the implant itself. You can develop severe arthrofibrosis. You can have soft tissue impingements on trochlear ridges within the articular bearing and several other areas. Patellar clunk syndrome, which we will address later on, is another common cause of intra-articular pain. Popliteus tendon impingement, component overhang or excess cementation that extravasates out into the soft tissues. And then, of course, you can have full extensor mechanism dysfunction. So again, patellofemoral maltracking that we just talked about. You can have patellar instability. You can have a patellar fracture. You can have patellar pain, such as in an unresurfaced patella total knee replacement. You can have lateral facet impingement. You can have severe patella baja if the joint line was elevated at the time of surgery. And then you can have excessive polyethylene thickness that will do that as well. Then, of course, you have frank extensor mechanism failure, such as quad or patellar tendon ruptures. Classic extrinsic or extra-articular etiologies of a painful knee replacement. Number one, hip pathology. Always rule out that there's an issue up at the hip, much like in peds. If you're examining the knee, you've got to examine the hip. You can have lumbar spine issues with stenosis or radiculopathy that can manifest as knee pain. You can have painful neuromas, especially the infrapatellar branch of the saphenous nerve. Like with any surgery or traumatic experience, the patients can develop complex regional pain syndrome. You can have vascular claudication that can lead to knee, thigh, or calf pain. You can have soft tissue inflammation, so pes anserine bursitis or medial gastrocnemius and semimembranosus bursitis. You can have patellar or quadriceps tendonitis. Finally, you can have periprosthetic fractures, so a tibial stress fracture, usually medially with subsidence into varus. You can have a patellar stress fracture, and you can have traumatic fractures to any of the bones surrounding the knee. So workup and evaluation of a painful total knee replacement always begins with physical exam. Is there an effusion? Is there erythema? Is there warmth? Is range of motion painful or painless? Is there any evidence of instability both in extension and flexion? Patellar clunk, as we briefly alluded to earlier, is a phenomenon where the patient perceives, and often you can hear, a clunk at about 30 to 45 degrees of flexion as the knee extends from a flexed position. It's usually seen when there is a posterior stabilized femoral component with a box, and you develop this large scar ball at the inferior pole of the patella. Then, as they go to extend their knee, that scar ball lodges in the box, and then jumps out of it all of a sudden once they hit that critical angle as they go into an extended position. And it can be painful anteriorly, and again, the clunk is classic. You can consider a diagnostic lidocaine injection as confirmatory evidence of an intra-articular etiology, especially if it's a confusing picture and you're not sure if it's intra or extra-articular. Next thing after physical exam, obviously always start with plain x-rays. You may see osteolysis, you may see a periosteal reaction, you may see a frank loosening of the implants or cement mantle defects. And osteolysis is most commonly seen on the lateral and posterior condyles. So usually it's the lateral view that's going to give you your best chance to see this, because the femoral component usually blocks the visualization of the condyles on the AP view. A CT scan can be used to evaluate for malrotation of components and help define osteolytic lesions or loosening. Bone scan can be used to detect loosening after 6 to 12 months. Usually prior to that, so an early total knee replacement, the bone scan is going to be hot just from the damage of the bone at the time of surgery. The other thing is it's really difficult on a standard bone scan to tell between septic and aseptic loosening or problems, and therefore a three-phase bone scan is usually what's helpful to help rule in or out infection as a possible cause, because on the blood flow and blood pool phases you will see increased blood around the components, indicative of an infection, whereas in aseptic loosening you will not see that. Labs, really what you're doing with those is trying to rule in or out infection, CBC, ESR, and CRP, and then finally aspiration. There are many different things now to evaluate for periprosthetic infection, including alpha defensin, some of the interleukins, leukocyte esterase, all kinds of things that will be covered in another presentation solely based on periprosthetic joint infections. So an infected total knee replacement, it may only present with pain that is constant and doesn't abate with rest or activity modification suggests possible infection. Acute and dramatic onset of pain after years of a well-functioning implant or pain-free knee is usually indicative of a hematogenous infection. You could also have persistent effusion, painless loosening, or it could be more obvious with signs of inflammation, purulent drainage, fistula formation, and frank bacteremia or sepsis of the patient. Workup, again, we're going to talk about this a little bit and we'll discuss in greater detail in the PJI talk as far as evidence-based workup and the Musculoskeletal Infection Society criteria. But if initial aspiration is negative but still suspected and the patient is stable, you may want to wait a week or two and try again. You also want to aspirate well after they have been off antibiotics, usually 2 to 4 weeks. So you never want to presumptively start antibiotics, risking the inability to culture a bacteria if you think they may be infected. A positive aspirate is considered a total white cell count of greater than 1,100 in a chronic knee, so one that is several years out from surgery and they present with signs of possible acute or chronic infection. On the differential, there will be greater than 64% polymorphonucleosites, especially in the face of an increased ESR and CRP. If those are normal, but these are elevated, then you might think more of an inflammatory or autoimmune process, but again, it may need further workup. An acute infection immediately post-operative, some studies have shown that a cutoff of about 27,800 WBCs and 94% PMNs may be indicative of infection as opposed to early acute post-operative immune response. But this again becomes very difficult and your index of suspicion has to be there based on your physical exam and the patient's presenting complaints. Again, all of this will be more thoroughly covered in our PJI lecture. The goals of any revision are, number one, clear the infection if that was the cause. Remove the old components with maximal bone preservation, restore bony deficiencies, restore the joint line, balance the ligamentous stability, and provide a new stable revision implant. The optimal joint line position is 2 centimeters below the origin of the medial collateral ligament, or about 2.5 to 3 centimeters below the lateral epicondyle. Another marker would be 1.5 centimeters above the fibular head. If multiple incisions are used in the skin, you want to use the most lateral incision as superficial blood supply comes from medial. You want to create minimal flaps, and they should be full thickness fasciocutaneous flaps. You want to preserve as much bone as possible during extraction of the implants. And once the implants are removed, the sequence is tibial tray, reestablish the flexion space, balance the extension, and then complete your patellofemoral reconstruction. So it goes tibia, then femur, then patellofemoral. With implant removal, you usually need a wide exposure here. You need to remove the polyethylene first, get that out of the way, then you want to remove the femur. And the reason you do that first is because even with a hyperflex knee, extracting the tibial component is extremely difficult to get around the femoral condyles, and so you may risk fracturing the tibia while trying to finagle that. So get the femur out of the way first, then remove the tibia, then go back and remove the patella if you are revising the entire knee. If you need, you can make an anteromedial bone window in the tibia, in the metaphyseal bone, to reach in centrally with a bone tamp and tap the tibial plate out in a retrograde fashion if you just can't get it out. The cortical window or osteotomy can be used for well-fixed and stemmed components. Again, you just go farther down or up the shaft depending on if you're in the femur or tibia. You want to use intraoperative fluoroscopy if needed to make sure all the PMMA is out of the canals, make sure you don't have a occult fracture, and make sure that your new alignment of all your components is fitting well so you don't risk a cortical breach or fracture with stem components more proximally in the femur or distally in the tibia if you're not sure. If all polyethylene component is what's in or a press-fit tibia, you want to cut across the keel and then excise them secondarily with a burr, an osteotome, a drill, whatever you need to. But basically, you take out your saw and you cut right underneath the implant surface and cut across that keel. For tibial platform reconstruction, you want to do a minimal freshening up cut perpendicular to the mechanical axis. Most systems, if you're using stemmed components now, will have a neutral slope cut. However, if you're not using stem components, you'll need to know what posterior slope is required for each implant, which may be different from company to company. Frequently, when you're extracting the tibia, you have bone loss, usually posteriorly, because that's the hardest part to get separated away from the tibia, and that part will usually stick to the tibia as it's extracted, so you'll have a defect back there. You may require augments, cones, metaphyseal sleeves, or a long stem to provide diaphyseal fixation and bypass the garbage bone more proximally. On the femoral reconstruction side, again, as we just talked about, you want to establish the flexion space first after the tibia has been established, and in order to do that, you may require posterior condylar augments on both sides or one side. You then bring it into extension, and you may need to change the distal femur cut or augment it as needed in order to restore the extension gap balance. If it's still unbalanced or unstable, you can increase the implant to more constrained, such as a CCK or even a hinge if needed. But if you're going to switch to that because of the loads that are transferred to the bone implant interface, you want to put at least a small stem on these, if not a diaphyseal fitting stem. For patellofemoral reconstruction, while doing the tibia and femur, ensuring proper rotation to provide good patellofemoral alignment is key. If the anatomy is distorted, you may need to assess for rotation with the trial components in order to achieve good overall alignment and tracking, and you may have to go back and recut your bones all over again. Don't be afraid to do that. However, if needed, you can always do a lateral release. You can change where you place the patellar button more distally and medially to help with tracking, so there are some other tricks you can do on the patellar side of things. You can also retain the previous patellar button if there's no signs of infection, it's an implant with a successful long-term history, it's free of visual delamination, damage, or wear, it's still well fixed, and there's adequate tracking, so you're not obligated to redo the patella every time you go in after a knee. So implant options, we just alluded to these a little bit. You have your unconstrained components, you have your constrained components, and then you have your mega endoprosthetic, so a distal femur replacement or a proximal tibia replacement. The unconstrained components are the same for primary knee replacement, cruciate retaining or cruciate substituting, and then the constrained, now you get to the CCK or a constrained hinged or rotating hinge knee. The unconstrained implants just talked about, same as primary total knee arthroplasty. You can only really use these if there's minimal bone loss, a stable joint, and you have your intact collateral ligaments. Constrained implants are where you go if you don't have the intact collateral ligaments or you have excessive bone loss and you need thicker and thicker polyethylenes and maybe a little bit of questionable imbalance or stability. These need to be used again with intramedullary stems. It does have a large central post to substitute for a deficient MCL or LCL. and it's used for instability, mild MCL or LCL deficiency, and again, you can also repair those ligaments at the time, and especially if you have flexion gap laxity or fixed varus greater than 25 degrees or valgus greater than 15 degree deformities. It has increased polyethylene wear, possibly secondary to the constraint. The knee is not allowed to move with natural motion, which leads to increased wear on the polyethylene. There's less of a pivot shift with this, and you don't get the rotational component that you get with normal knee kinematics. So here's an example of the CCK component with stems pictured on the right side, but you can see that large post completely fills the box on the left side there. If you have to go to a hinge knee component, the tibial component rotates around a yoke, which is the tibial connecting post that allows the polyethylene to rotate around it. Some of the more modern implants now have a 30-degree block where it allows only 30 degrees of motion. Some of the older implants were completely rotationally free. These are used for global ligamentous insufficiency. So this is where your MCL and your LCL are insufficient, where you have severe flexion gap laxity, you have post-traumatic or a periprosthetic fracture, a multiply revised knee replacement, hyperextension instability, especially seen in polio or other neuromuscular disorders. And basically, if you have to resect too much of the knee to fill with a conventional polyethylene, you have to switch to a hinge, just because it bulks up the distal femur a lot more, and you can always go to a distal femur replacement if needed. Due to the high constraint of these components, increased risk of aseptic loosening is seen if short stems are used. However, failure is more often due to the complexity of this surgery and to the status of the patients rather than to the actual hinged mechanism itself. So again, it suggests that we have a lot of control over patient outcomes and implant failures by making sure we get as well balanced of a knee as possible. Even if we have to go to a constrained implant, you want to make sure that you don't have excessive patella baja or alta, or you have excessive stresses and strains on the implant. So here's an example of that rotating hinge. So the axle goes across the distal femur that fits in with that yoke, which is the metallic part of this implant that's sticking down into the tibia that allows for free rotation around that yoke. And so that's sort of the mechanism behind this, and the reason you make it rotationally free is because of the natural rotational motion of the knee. If we were to just create a fixed hinge, eventually you would torque this implant out of the bone or actually fracture the bone from those excessive torsional forces. Of course, we can always bail out to a mega endoprosthetic if needed. This is when there's just excessive bone loss, global instability, multiply revised knee, whatever major problem there may be, and you can do a distal femur replacement, a total femur replacement, a proximal tibia replacement, or combine the two if you need to. However, these come with increased complexity, increased operative complications, increased postoperative complications, and decreased longevity of the component, as well as decreased function of the patient. The more muscle you strip off of their bony attachments, the less likely they are to have good, meaningful strength and function. So informed consent for patients and making sure their expectations are appropriate with respect to the goals of the surgery is going to be key when you're having these sorts of discussions with patients. So how do we address minor bony deficits when we're not talking about a mega endoprosthetic? So this helps us determine, do we need augments? Do we need stems? Do we need cemented stems? Do we need press fit stems? Do we need cups and cones and all of those things? So first thing you want to look at for your bony deficit is it contained or uncontained? So contained basically means, if you picture a cube, only one of the sides is open and everything else is closed. Uncontained means at least two of those sides are open, where if you were to fill it with cement, if it's contained, you can fill it up right to the top of that cube, no big deal. But if it's uncontained, it means you're dumping cement in and then it's coming right out some other wall. So does it have a peripheral cortical rim intact? The AORI, or the Anderson Orthopedic Research Institution, has classified these deficits, which help guide your treatment. So a type 1 deficit is the metaphyseal bone is intact and you have minor bone deficits, usually contained. So you can just bone graft them or cement them and not have to really address them with your reconstruction. Type 2 is where the metaphyseal bone is actually damaged. So you have cancellous bone loss that necessitate an area of cement fill, augments, or the beginnings of perhaps a sleeve or cone. These defects can occur in one condyle or plateau, which is 2A, or both, which is 2B. Type 3, finally, is you have deficient metaphyseal bone. So this is excessive bone loss that will compromise fixation and stability. So these are ones where you may need a mega endoprosthetic, or you will definitely need some sort of diaphyseal fitting stem to bypass those defects, and probably cones or sleeves to fill those defects. Clatworthy and Gross also tried to define bone deficiency, and so Type 1 here is contained with metaphyseal bone intact, similar to the AORI. Type 2 is contained with damaged metaphyseal bone requiring bone grafting or cement fill. Type 3 is non-contained, so now you need to do bulk allograft, cones, those sorts of things. And then 4 is non-contained circumferential defect requiring segmental distal femoral or proximal tibial graft or replacement. So this is just a slide, again, talking about what you can do depending on the size of those defects and whether or not they're contained or uncontained. I'll let you kind of peruse this at your own leisure. So cement and screws can be used to fill some of these defects, where basically the screw acts as rebar for the cement to increase its strength and give it something to fix to. It's simple, it's inexpensive, and it's very efficient. It's very quick to quote-unquote rebuild a defect using this. Typically this is used for smaller defects, less than 5, maybe 10 millimeters deep. Some advocate for larger defects as well. Screw augmentation is recommended to enhance biomechanical properties of this construct, and if the patient is young and active, it may be more advantageous to use allograft in order to get more biologic fixation with creeping substitution rather than the cement and screw construct. But with this, you have satisfactory midterm results with this technique by filling these gaps. You can use morselized cancellous allograft. This is typically reserved again for contained defects so that this doesn't just leak out into the tissues. It's again more attractive for younger patients where you want to keep bone stock and keep biologic fixation as much as possible. It incorporates similar to cancellous autograft but at a slower rate, and you may consider impaction allografting for larger defects or segmental defects. That's where basically you put it all the way down where your stems are going to be if you have a big dilated ectatic canal or metaphyseal region, and then you impact your implant into that, which essentially then crushes all the graft to the periphery but sandwiches it all around the implant to help out with interdigitation. Structural allograft can be used for large and structural bone deficits, usually greater than 1.5 centimeters in depth. Again, more advantageous for young patients where you're looking for biologic fixation. The disadvantages: graft resorption, graft fracture, collapse, graft host non-union, and infection. Modular blocks or wedges can be used. These are to fill, again, segmental defects. These are the augments that you'll normally place on these. You may have to do step cuts in the bone to even things out, so they do have a fiddle factor to them, but the advantage is they're very versatile. You can rebuild most deficits with this. The disadvantage is you usually have to cut a little bit more bone to make them fit properly, so you do lose some bone stock while compromising that with this. The next step as you develop larger and more structural defects are the porous metaphyseal cones or sleeves. These are for large tibial and femoral deficits. There is lots of short-term and mid-term evidence now supporting their use. Essentially what they do is they get press-fit interdigitation in the metaphyseal bone, and then the implant gets cemented to them rather than the deficient bone. These are usually for the AORI 2B or 3 defects. Other things to keep in mind is, again, young patients may do better with allograft to preserve bone stock. Small defects may be better suited with impaction grafting or augments instead of this, rather than clearing more bone to make one of these fit. And large defects with insufficient bone support or decreased ability to get osseointegration may need a custom prosthesis or megaprosthesis rather than one of these. Finally, if all else fails, mega endoprosthetic. So the next thing is you need to make sure you get your exposure for all of this, depending on how much work you have to do, how far up and down the femur and tibia you need, and any issues with the extensor mechanism blocking what you're trying to do. So there are all kinds of different extensile approaches. These are what you resort to get your exposure after you've tried everything else conventionally. The typical convention is a medial parapatellar approach. Then you want to try and do an entire anterior synovectomy in order to reestablish your gliding tissue planes and your gutters. Usually this alone is enough to get you the exposure that you need, but occasionally with tight scar, long-term issues, multiply revised knees, you still can't get the extensor mechanism out of the way to expose the femur and tibia appropriately, so that's where you bail out to these extensile approaches. First one is the tibial tubercle osteotomy, where basically you osteotomize the tibial tubercle and flip the extensor mechanism open. The advantage to this is afterwards you fix it and you have bone-to-bone contact, so it may heal well. But the big disadvantage is usually you have to leave them in extension for a while. You've got to let it heal. And a lot of patients will go on to a fibrous union, but some of them may not necessarily be a problem. However, if you fracture that little cortical fragment or they do go on to true non-union and they're symptomatic, it can be a bit of a problem. The next is this banana peel exposure, where basically you have a quadriceps snip and then you elevate the patellar tendon off of the tibial tubercle from medial to lateral, but you leave the lateral and distal soft tissue attachments to the periosteum and retinaculum and everything else that's there intact. Then at the end, you just close it back down and it actually has surprisingly good results. Quadriceps snip is the only extensile approach not shown to affect the functional outcome or the rehab protocol, so you don't have to immobilize them or restrict their extension strength and all of that stuff. Essentially what it is that stereotypical medial parapatellar arthrotomy and then this additional angular snip that goes in line with the vastus lateralis fibers and up into the muscle itself that enables you to really swing open the door of the extensor mechanism there and get your exposure. The next is the quadriceps plasty with a VY advancement. It's essentially that medial parapatellar arthrotomy and then an inverted V that goes down below the vastus lateralis, and then you can flip open that whole extensor mechanism, and then you can always lengthen the quadriceps tendon with a VY advancement if needed on the closure. This is used for knees that don't get much flexion, knees that are incredibly tight, tons of scar tissue, but the problem is most, if not all of these patients end up with a pretty severe extensor lag, beginning at 10 degrees and usually greater than that. Many of my patients have probably somewhere between 15 and 25 degrees of extension lag. Quadriceps turn down is basically the same approach. You just extend that even farther down the lateral retinaculum and really peel that thing open. Similarly, you can do another VY advancement upon closure if needed, but again, extensor lag is a big problem with these exposures. If you have extensor mechanism ruptures now, this can be catastrophic. You can attempt a direct repair if possible, but often it's not, especially if it's chronic or irreparable. You're going to need autograft or allograft, either hamstring, Achilles, whatever you can to try and reproduce this. You may have to even consider a patelectomy plus or minus an allograft extensor mechanism reconstruction, where basically you take an allograft bone block of the tibial tubercle, patellar tendon, patella, and quadriceps tendon and basically replace that part in the patient. The problem with these is it's a big chunk of dead tissue, so extensor lag is a big problem even if it heals well, but infection, failure, pull out, all kinds of issues are seen with these. Outcomes usually with that sort of reconstruction are generally poor. The next thing is this mesh reconstruction, where essentially you use a rolled up mesh via a bone tunnel and screw and cement fixation into the tibia and then up over the extensor mechanism to essentially give it something to scar into and scar down to. It does work decently well, but again, extensor lag's an issue. Again, you have a big chunk of artificial stuff right below the skin surface, so infection is an issue with these. So in general, extensor mechanism ruptures do not do well in patients, and these reconstructive methods are sort of salvage methods that may or may not even work. So some of the best treatments for chronic extensor mechanism ruptures are either a fusion of the knee or a drop lock hinge knee brace with extensor assist that will help the patient ambulate with a functional external extensor mechanism. So here's an example of that extensor mechanism reconstruction with the mesh, where basically you have that screw through the bone tunnel with the mesh cemented with the tibial component into the proximal tibia, and then you wrap it around and suture it to the extensor mechanism that allows you to get full reconstruction and reconnection of the extensor mechanism to the tibia. So that wraps up revision total knee arthroplasty. Again, in the classroom, we're going to go over several cases of this that'll help a lot of this make sense and conceptualize some of these issues a lot better with visual aids. And so I'll leave you with my Pacific Northwest Pride slide. Face Rock, right off the coast of Bandon in southern Oregon, which is an amazing, gigantic rock that looks exactly like a face sticking out of the water. So thanks for listening.